Welcome to the Low Carb MD podcast. No one is beyond help. No one is beyond hope.
As we have always said, we are bringing you medical information and cutting-edge science, but none of this is medical advice. Please seek out input from your own doctor.
Hello and welcome back to the Low Carb MD podcast. Turo, good to see you, man. We've been divided lately, man. We've been too busy.
No, it's always a pleasure. Today, it's an extra special pleasure. Somebody who I've been communicating with over the past couple of years, trying to get her out of the empire, getting her away from the dark side, and now she finally crossed over. Dr. Christy Kesslering. And I'm a huge fan because she deals with a very important area that's near and dear to my heart, oncology and radiation oncology. She's board certified radiation oncologist. She did her bachelor's at UCLA. Sorry, Brian, I know.
Yeah, I know it's hard.
It's hard to hear that. She went to medical school at Loyola, and she did her radiation oncology residency at the University of Wisconsin, and she practiced as a radiation oncologist for a number of years. I hope I got that right. And her focus in the past, for a long time, has been metabolic health, and I think that's what you're focused more on now, if I'm not mistaken. Is that right? Can we do first names, Dr. Kesslering?
Absolutely. Kesslering is a tough one, I know. So yes,
Yeah.
Christy is absolutely fine.
Christy, so just tell us. We'll always start with, what brought you to medicine? What brought you to get into, I'm just curious, you went through years of training, to get to complete even your medical undergraduate training. So there was something that really drove you to medicine, and you've practiced for,
Decades.
20 years, right? So what brought you to this field, and what's changed lately?
Yeah, so I went into medicine, no medicine in my family whatsoever, but I was kind of the math and science geek. I really liked, organic chemistry, crazy things like that, and thought, well, medicine might be a good application of these fields that I really enjoyed. I got into radiation oncology because I really liked the three-dimensional imaging-based work, but yet it was a very patient-forward. It wasn't radiology in a back room. It was actually working with patients. And I learned a lot in my residency. I had some great mentors that taught me how to educate patients. And a lot of times the patients would be like, oh my gosh, I just learned more about my disease in this last hour than I have in the last 7 years that I've had the disease. I would really like to talk about science and talk through how we got to where we are today in their particular case. And as I practiced radiation oncology, which I absolutely loved, I worked with a lot of wonderful colleagues as well as really fun patients, and they were very committed. When you get a patient with cancer, they are like, what should I do? What do I need to do? As opposed to kind of the run-of-the-mill not conventional, but primary care. It's kind of like, okay, how many times can we talk, have the same conversation? I feel like I have a very motivated patient population for the most part. And as we all know, obesity is very much related to cancers. And I had over the many years of practicing radiation oncology, had kind of honed a practice of a lot of breast cancer, endometrial cancer patients. I saw others, but that's a very obesity-driven disease. And as I struggled with a little bit of weight gain around college, stopping, my sports, and then, getting a handle on that, and then having some babies. Now, I struggled with weight myself. And so I kind of dug into the weight loss literature myself, and realized that, this is not about calories in, calories out. I learned Atkins low carb diets back 22 years ago. So that's about when I started my own personal journey, but I didn't understand it from a true insulin metabolic perspective. It was still about weight. And when I kind of started to work with patients with weight loss, like, hey, let's improve your outcomes. Let's improve, maybe your decrease your chance of recurrence by optimizing your diet and lifestyle. But then I got more into this experience or understanding of metabolic health, insulin, IGF-1. These are growth factors for cancer. And so I really love learning things from people like Dr. Nasha Winters and Travis Christofferson and Dr. Seafried. And a lot of these people were putting out information on these growth pathways for cancer. And so I really dove into that literature, started understanding cancer, the root causes of cancer. It's not rotten bad luck, which we hear from our colleagues all the time. It's not genetic per se, right? We kind of talk about, it's familial, right? Your family has learned to eat and live in a particular way. And probably, from an epigenetic standpoint, we are turning on certain oncogenes, turning off tumor suppressor genes. And then, yes, everything kind of changed as I really had started doing deep dive studying, either on my own time, or actually eventually leaving conventional practice to really dive into this and work with patients who want to make metabolic changes, who really are digging into it is more than a conventional medicine Band-Aid on a problem, that I need to do something different. And to be honest, patients love having something to focus on, to like, I have control, as opposed to being just a passive participant in the conventional world. So there you go. So now I do metabolic health with primarily cancer patients, but sometimes, that spills over into others, their family members, their friends that are having other issues. So I see a little bit of everything, but primarily I'm seeing cancer patients.
Are you doing radiation still now too, or have you mostly shipped over and you're doing?
Yeah, 100% telehealth, metabolic health.
Wow.
I left conventional radiation oncology just about 2 years ago now. So.
Wow. Yeah. And of all things, I mean, because this is just fresh in my mind. I have a patient who has DCIS they found, right?
Mm-hmm.
And she's sending me all these videos. Look, here's what Gregor says and all these things. And you go, oh my gosh. But the surgeon's like, okay, we got to do double mastectomy. And like she has none of her tumor markers are concerning. And you go, oh my gosh. She goes, can I watch? And it's such a scary thing. So when we know it's there, we want to just take it out. What do you think about how do we advise these people instead of being like, a lot of people go, well, I'm not taking any chance. I'm getting a hysterectomy, I'm getting everything out. And then you go, well, let's reassess. So how do we do that, like to help patients? Not to be overly aggressive, put it that way.
Right. Well, first of all, I want patients to understand that cancer, or precancers, we can call DCIS sometimes, is that these are your check engine lights going on. This is no different than getting a diagnosis of diabetes or hypertension or something else. Like, bam, something now is so, off that you now have this diagnosis, but it is not an emergency. So number one, I usually say cancer is still not an emergency. We can take a step back and we can say, okay, what is this trying to tell us? Now, most of the time it's trying to tell us that we have a metabolic dysfunction. There's a lot of different ways to approach it. So do I have some patients who are super conservative? Like, I don't want to have my breast taken off. I don't want to have this taken out. And do I work with those people? I do. And we actually have seen mammograms turn back to, we can't find that anymore. But sometimes it's nice to get it out because that allows people to sleep at night. But that certainly hasn't changed the reason for the cancer in the first place. So if they're just going to cut it out and continue to live the same life, well, then we're going to be back with a recurrence or another type of cancer or something else, right? So I always say that if we don't address root cause at some point, then we're apt to repeat the process. So, but if we think about BRCA genes, so that's usually when people are looking to do bilateral mastectomies, oophorectomies, take out ovaries and take off breasts because they have this breast cancer, ovarian cancer gene. But as we know, genes are not destiny. genes can be turned off or turned on. And if we look at the data, not every BRCA 1 or 2 patient gets cancer. So instead of just saying, let's cut off everybody's breasts and take out everybody's ovaries, why don't we look to see why are those patients who didn't get, or people, women who did not get cancer, what are they doing differently? Right? They are probably living a lower inflammatory, lower insulinogenic diet and lifestyle, and therefore they are not turning that gene on. So I would just like to come at it from a completely different perspective. And I think we forget to look at those healthy folks, the ones who don't get disease, the one, like, what are they doing different?
Yeah, when you look at the percentages, I was really surprised at how few actually progress to, but like you're saying, the important thing is, okay, can I take care of my lifestyle? Am I stressed all day? Am I drinking too much? Am I eating too much? And change your lifestyle, because the problem is, I hear people, they say, you have DCS, we're going to do a mastectomy or a lumpectomy. But they never talk to them about, okay, how did we get here in the first place? What brought us to this point? What are we going to change lifestyle wise? And, we just interviewed Maggie from Cancer Revolution. You go,
yeah.
Like, it's amazing when people go, okay, I'm not going to worry about this dumb stuff. And then you go, okay, why don't I just stop worrying about the dumb stuff before I get cancer, rather than trying to reverse the disease process, right? Preventing it rather than getting this stupid thing.
100%, 100%. But I will also say that even though, there's some wonderful data in the conventional literature about the combination, right, of kind of addressing metabolism as well as, using conventional therapies, and how they really do seem to complement each other. But I will still see patients. I love it when I get the patients before they've jumped in to conventional medicine, because we sometimes have time to get them in a better healing, better robust state when they are doing it, and then prepare. Like, how are we going to prepare? What are we going to do during and after chemotherapy or radiation therapy, et cetera? But, a lot of times we'll start to see tumor markers. So for instance, I have a prostate cancer patient who was, again, being encouraged to start ASAP with treatment, and reached out to me, and we started working on optimizing diet and metabolism. And lo and behold, within the first 6 weeks, he's dropped his PSA by 50%, as he's getting ready to embark on treatment. I mean, that's pretty impressive, right? So we see that, we can see tumor markers, those cancers that have tumor markers, not all of them do. But we can start to see that, or we can start to see improvements in breast tumors or lymph nodes under the arm, or skin diseases, skin manifestations of cancer, even before we're embarking on some of those therapies. And those therapies, again, may augment what we're doing, but we certainly, there is data that shows both of them have efficacy.
Yeah, and that's exciting, because you think about, from a prostate cancer, like, if it's, when you have cancer, the trajectory should be going up and up and up, not down. So even if it stayed the same, you say, okay, we're making progress, right, at some point, because it's not progressing, at least,
well, even one of my patients who was multiply recurrent, so I didn't see him until they were starting to recommend chemotherapy for prostate, which means you're pretty far down the line of therapies. And he found me, and the first time we repeated his PSA, it had still gone up, but his doubling time had significantly slowed. And he's like, this is awesome. Like, it should have been at this time, it should have been, double where it was. And now it's only like a quarter as high, and now it's moving down. So it's fun to get patients excited about the fact that they're having some impact on their own cancer outcomes.
I think there's some pretty strong evidence linking sort of insulin resistance to prostate cancer. One of the frustrations I've had with prostate cancer is this, the lack of adoption of, so let's give the listener a little context. Prostate cancers are typically slow growing, right? And very often people may die of poor metabolic health before they die of prostate cancer. Certainly some are very aggressive. And the problem with screening in the population is that we have this biomarker PSA, which is commonly used, but sometimes it can be falsely elevated if you have a prostate inflammation, or it could be from an infection, And the approach to an elevated PSA historically was to go do a biopsy. And these biopsies can be very problematic because they're dirty, really, like they're really, they can get a lot of sepsis from this procedure. And so, for as long as I've been looking at this field, I'm like, well, why don't we just do MRIs? And for 10 years, I've been saying, well, why don't we just do MRIs? Look at with MRIs. And finally, like in the past year or 2 years in the field of prostate cancer, MRIs are now acceptable prior to a biopsy, right? At least to just see what it is we're dealing with, to aid in a biopsy if it's needed. And what they found is the need for biopsies have gone way down. Right. So I've been frustrated at the field of oncology and radiation, radiology as it relates to oncology. And really, I think the most frustration comes from the insurance companies because they won't cover these really basic tests like, hey, you got this biomarker that's elevated. Well, let's actually see what's going on.
Causing it. Yeah.
So what do you think about, how do you feel about, traditional screening modalities and, as it relates to, prostate MRIs, even with breast cancer? I've always thought now breast MRIs are finally getting covered, in addition to, for high risk patients, so
yes.
what's your thoughts on this?
Yeah, I think that imaging can certainly help. Although I will also say that, especially in breast, MRI can very much overcall, meaning that they might say, oh, this is, you have all of these masses, and somebody does a mastectomy and it turns out that they're not all cancers or a big tumor that's really a small tumor. So we have to understand that every single imaging modality has pros and cons, and every single screening modality, tumor markers, et cetera, have pros and cons. And that's why I think, that many of these screening, recommendations have been, you need to discuss the pros and cons of screening or whatever with your provider, because there's at what point in time in your health, in your age, is this really necessary at this point? Is this really high on our list of fines, et cetera? But I will come back to the prostate and PSA. Is, guess what? BPH, swollen prostates, right? That drives PSA, but guess what? It's another insulin resistance disease, right? So anything that grows cells is typically a metabolism, an insulin or an IGF-1 related disease. And there's a lot actually more on IGF-1 in prostate cancer, although definitely insulin as well. And so I think that I wish that we would do these almost like calculators, right? That, okay, let's look at your PSA and your insulin and your IGF-1, and okay, now what is your risk of having a prostate cancer? But even then, in my world now, my new world is, let's address your insulin resistance first. Let's see what we can do to help shrink your prostate, to, maybe help improve. So I do have somebody who's in active surveillance. That's at least a nice thing that's happened, in the prostate world, is a lot more men are undergoing active surveillance. So even though they're diagnosed with a prostate cancer, but if we're not addressing the root cause, what are we doing? We're just waiting for the PSA to get high enough that, okay, now it's time to cut it out or treat it with radiation or whatever. But if we're really addressing, that root cause issue, I have, some patients whose PSAs are going down and their MRIs are actually getting better.
Yeah, that's amazing to see. As a matter of fact, I was just, while you were talking, I was just thinking about how ridiculous our system is. When I interviewed for medical school all those years ago, I actually had to get interviewed by a urologist and who did this surgery. So anyways, he's talking about this young guy in his 30s who had prostate cancer. They did a PSA because some reason he said something just didn't seem right. They felt something, whatever. Anyways, PSA through the roof. He does a prostatectomy. The insurance would not pay for this. They said the screening was not indicated in his age group. They still never paid for the screening. And he's like, how can that be when you have the disease that we're looking for? And they say it wasn't indicated. So you see these crazy things in medicine where it's just like people can't think outside
So
the
backwards.
box.
Yeah.
And then, in your case, you start looking and saying, gosh, if we can address these metabolic things. And the other thing that it's so astounding to me that we're having psychiatrists using a ketogenic or a low carb metabolic approach, oncologist, cardiologist. You go across the board, everyone's like, oh, it's helping my problem too. And we have to, and our job as primaries is look at the whole picture. It's like, okay, if it can help you from a cancer standpoint, a mood standpoint, a life quality of life standpoint, all these things, and you go, how could it be controversial at some point when you see all these different areas saying it's helping my area of medicine? Like oncology is probably the scariest area, and it draws the most compassionate, kind people that really want to help people. But if you start talking like this, they think you're nuts and they tune you out.
Yeah. And again, they, fall back on the same conventional dietary wisdom that every specialty uses.
Oh,
Low fat, more Mediterranean, meat causes cancer.
whole grains. Don't forget the whole grains.
Don't forget whole grains.
Healthy
yes.
whole grains.
Lots of fruits, lots of, anyway. So it's sad. And when I have patients that are working with me, right, and they're with their conventional, I have literally printed words from a patient whose oncologist told her to eat sugar.
Oh my God. Can I just talk about this?
Source.
So the problem right now is the American Cancer Society recommends based off of data.
It's not based on data.
Well, with healthy user bias, right? We're talking about based on data for observational data, which is just incredibly prone to bias. They recommend basically the standard guidelines, which is more fruits, more vegetables, and more whole grains. And this is in contrast to some early data with ketogenic diets for glioblastoma, ovarian cancer, breast cancer, that have shown that it's could be beneficial in addition to conventional sort of treatments. So, I've always found it odd that they had this sort of blanket recommendation for cancer with very sort of, faulty data, which is literally a bias against these low carbohydrate approaches. And I think if we ever get diet therapy approved, in addition to sort of treatments for cancer, the first one will be glioblastoma. But I think breast cancer will be the second one right behind it. I was looking at the National Cancer Institute. They have a big trial of metformin in breast cancer recurrence, which I think is due any time, somewhere in the next 6 months to a year. The results will be out. And this is a massive trial. I think it was like 20,000 women with breast cancer, randomizing them to metformin or placebo for breast cancer recurrence. And what are they basically saying? They're basically saying that if we get you to poop out sugar and become slightly more insulin, sensitive, that it's going to lower your chance of getting breast cancer. And this is phenomenal because I think this will prove a lot of what we all think and know, which is, they're showing the mechanism for which we all, I think, are hanging our hats on, that we suspect and we know the way in which, focusing on metabolic health would help these cancers. So I wanted to hear your thoughts on, what do you think about diets in general in this vulnerable population? And what do you think about sort of the data, that's coming or that's already here to help us understand where does diet fit into all this?
Well, I think it's far more powerful, but let's talk about metformin real quick, because there was a study where they put high-risk breast cancer patients on metformin, randomized trial, so half and half, and then looked for cancer recurrence or metastases. And they did find that there were more patients on the metformin, but it was pretty dramatic, but it didn't reach statistical significance. But if you then looked at fasting insulin levels, those who had lower fasting insulin levels, regardless of whether or not they got metformin, had better outcomes. So metformin was acting as a band-aid, right, on the problem, and got a few more women into that lower risk group. And my fear, to be honest, from the metformin data is we're going to go down the metformin and the what are they called? You guys know the SLG
SGLT2 inhibitors.
Yeah. That's
Yeah,
what
like those will drive that process, or because we live in conventional world in the pharmaceutical model. So that like diet's going to get left behind, I think, except for those patients who are savvy enough. When we look at, there was a randomized trial in gynecologic malignancy, so ovarian and endometrial cancer patients getting chemotherapy, but half of the patients were put on the American Cancer Society diet and half were put on a ketogenic diet. And guess who lowered insulin and IGF-1 and sugar and visceral fat more? Big surprise, ketogenic diets. Despite the fact that they're eating a bunch of meat, eggs, butter. They looked at their diet recalls.
But Harvard just said
had,
that meat raises insulin and it's going to cause
diabetes. So
diabetes.
Yes, meat with McDonald's, French fries, and
exactly
Coca-Cola,
right.
Absolutely. But so anytime we combine, sugar and fat, or even sugar and protein, we will drive up glucose, insulin, IGF-1. But fat or protein in the setting of fat actually has some very interesting different changes, right? So we can see glucose, insulin, IGF-1 coming down. We can actually see glucagon going up, and glucagon's a hormone that actually helps inhibit cancer growth. So very interesting.
Yeah, it's interesting too, and that
things.
brings in fasting with Jason Fung also, is if you're elevating your glucagon levels, then
so fasting raises glucagon, but so does protein, but not in the setting of carbohydrate. And how do we, if we're eating plant-based proteins, we're bringing in carbohydrate with our protein. And if we're eating animal-based protein, we're bringing fat in with our protein. So again, some beautiful differences in mechanisms that we can, really push to see some really wonderful benefits in cancer. And my fear really is, because of our current clinical trial environment, that so many of them are funded by pharma, that who is going to fund the trial that looks at diet? And it's also very difficult to control for a lot of things, right? Because now patients are responsible 24/7 for following the rules, as opposed to coming into your office, getting an injection or a pill and going home. So it is a little bit of a tougher model to assess, but that's why in my practice, I am asking them to do a little bit of diet tracking, testing glucose and ketones, so that I can be looking at a few markers, a few data points in between getting labs, because they're really the only thing that I care about is, have you lowered insulin? Have you lowered IGF-1? What do your inflammatory markers? Is LDH, which is a marker of mitochondrial health, is that in the optimal range? Let's look at some of these markers, and are you improving your health or not? And sometimes I'll see people not improving, and we have to go dig back into some of their data and say, listen, you are under eating fat. Like, you are eating too high of a carbohydrate and protein, which is driving those other markers. We really need to push that ketogenic aspect. And so not necessarily to the levels that, maybe seizure kids need to be on, but definitely more than we think about. So there's a lot of times in the low carb community, we're so focused on just eating low carb. And that's not quite what we need to do from a cancer perspective, or maybe from everybody's perspective. Like, we tend to focus on the high fat proteins. But I really do have to help people kind of optimize it, because it's so counter to what they have done for the last 20 years or whatever. Like, oh, but fat is bad and meat is bad and dairy, like butter bad, like it's so hard to kind of get around that. And even in the cancer literature, right, there's so many people out there advocating for these plant-based diets. And again, meat causes cancer and dairy drives up IGF-1. And, and it's like, we have to understand context. We really, so I do a lot of education.
Yeah, I mean, it's not just the IGF-1, the 5-NU-C, the TMAO. I mean, they have all of these like surrogate endpoints. And it's funny, oncology, it's such a weird field when it comes to nutrition, because there are diehard plant-based people, there are diehard low protein people, there are diehard low carb people. I mean, it is like literally you have this sort of range of of approaches. And what I worry the most is leaving people very vulnerable. Like, what do I do? And sometimes I have like young patient with metastatic breast cancer, and she's just like, tell me what to do, Tro. And I'm like, well, it's not exactly clear, right? You're going to get 5 different opinions and you're going to get 5 different answers. I was like, you just have to be healthy. And exactly what you said, which I have to echo. And I know, Brian, you were looking to say something, but just let me say this one point, which is, the end result. How is your quality of life improved? Are your biomarkers improving? I think that's the most objective measure. We're never going to have double-blind, placebo-controlled trials. How are you doing? The person in front of me, your spiritually feelings, your labs, your like, how are you doing personally is the best way to go, in my opinion.
Well, I will say though that using the objective measures of insulin and IGF-1, and I look at a lot of nutritional markers, because what we see really with any diet, right? Low fat diets, lower glucose and insulin in some people. Some people feel better, but ultimately we end up with micronutrient deficiencies or something else. And so I do say, like, talk to anybody who went vegan or vegetarian. They almost always feel better for about a week or 2 or 3 or 4 because they've cut out the worst foods. And so I will say that it's more, that's why I like to do labs, and my tagline is data-driven health, because I want to see before we end up in the problem where they develop the next issue because they're heme iron deficient, or they're B12 deficient, or something else. So but I every single diet on the planet takes away the worst combination foods, right? Our processed baked goods, high sugar, high fat, soybean oil, rich food. So again, any diet is going to be better than a conventional, standard American diet. But I have a lot of cancer patients that are coming from the classic Mediterranean, pescatarian, vegetarian, low meat diet because they've been following all the rules, and they end up with a problem.
And that's the point I was going to make is like, okay, look, you come to me and you're on a low fat diet for the last 30 years, you got cancer. Eating a low fat diet is not going to help with this process. You got the process with that. So when I was in med school, one of my friend's dads told me he was drinking noni juice to reverse his cancer. And I was like, okay, how long have you been drinking noni juice? 15 years. So you've been drinking 15 years and you got cancer while you're taking it. Why do you think that's going to reverse your process? Right? It's not,
Right.
That's not the answer, probably in your case. It may be for other people, there may be stuff out there. So I think that's part of it, is saying, okay, let me change what I'm doing. If you, like, I have had a lot of vegetarians who are morbidly obese and diabetic, and I'm like, okay, it's not working for you. We had to change, because you could be vegetarian, eat Oreos all day and be vegetarian,
Right.
right? It's like, people know,
And,
inherently you got to make changes and cut out the processed garbage at least.
for sure. But I have had patients who were eating what everybody would consider a really clean vegan diet, and their cancer team told them they should eat more fruits and vegetables. And they're like, that's all I've been eating for the last 10 years. Like, I can't possibly eat more fruits and vegetables. And, so it's like this, like, we just have these like complete blinders on sometimes, that we keep saying the same thing, but it's really about diving deep and understanding metabolism and nutrient deficiencies and, immune function. And if we are not supporting those essential amino acids and essential fatty acids and, good healthy fats and cholesterol that actually support our hormones and our neurotransmitters and, in our immune function, well, then we're bound to break down.
I would love to ask your opinion on this, since you're so far more in depth than Tro and I are in these areas of pathways of malignancy, because we know if someone has a compromised immune system, they're going to have an increased risk of malignancy across the board. So high sugars, high insulin, that contributes to this. Interleukin-6, all these things I'm looking at, when we're so pro-inflammatory all the time. Like, what do you think are the major pathways? Like, we go, okay, these are the ones we really want to hit. I know it's kind of like when you're stressed and not sleeping and drinking too much, you got to break that cycle. And how do all these things fit into this, to the physiology of developing cancer?
Well, we can talk about from, just an oxidation, like when we're burning cancer, right? The dirty fuel, we're creating more free radicals, we're creating more oxidants, reactive oxygen species that can damage. So all of these things can damage mitochondria. Mitochondria are the damaged mitochondria is the first step really in developing a cancer. What's beautiful really is when you're following an optimized ketogenic diet. So I prefer animal-based ketogenic diets. I think those are far healthier, with adequate nutrients. Well, we're quieting inflammation. We're quieting the insulin signaling. We are improving those micronutrients and macronutrients that help us heal. So, and very interestingly, right, I think we know from our psychology, neurology folks is that we start to improve mental health. And so the anxiety, depression, the stress, I always say that we don't change your stressors, but your response to those stressors seem to improve. So now instead of, oh my gosh, this mountain is in front of me, or flying off the handle, it's like, oh yeah, I got this, like everything kind of mellows out and improves. So I try to get away from the whole pathway philosophy like we have, right? So we have all of these drugs in oncology, like this blocks this pathway, this blocks this pathway, this blocks this pathway. And we have the same thing in the non-conventional. There's lots of supplements and repurposed drugs. Let's block this pathway. These are Band-Aids on the problem. Can we just keep going back to what is driving these pathways in the first place? So just like you see somebody with a new diagnosis of hypertension, you can give them a drug and it will lower their blood pressure. It will stop that pathway. Or you can have them go on a low carbohydrate diet, and guess what? They reverse their hypertension and they don't need the drug. So I come at cancer in the very similar way that any of the drugs and the supplements and the repurposed medicines can be a Band-Aid, a bridge. It can help buy us time. It can, but if we're not addressing the root cause and kind of turning off all those pathways, then we're just going to fail ultimately.
Yeah,
And I think,
oh, go ahead, Tro.
no, go ahead. I mean, it's such a holistic process too. Sleep apnea can drive oxidative stress. I mean, food contaminants can drive oxidative stress. The amount of carcinogenic substances in our everyday lives that we just accept is just astounding. The heavy metals that are in our food supply, the various, carcinogenic substances in our beauty supplies and our cosmetic and sort of hygiene, products, the stuff we, clean our homes with. I mean, the
Kill your weeds
issue
with.
Yeah, absolutely.
Or emulsifying all your ice cream and all that. I mean, we just don't realize that when you look at an ingredient list, you go, oh my gosh, like it's crazy when you look at these things.
It's all about education. So those things come in. So as part of my consultation, we are talking about those things, and you can often see them in labs. Like you might see GGT through the roof, like there are detoxification pathway issues, like you have too much coming in. I sometimes will look at ceruloplasm, which can show kind of an estrogen dominance because all of these chemicals are estrogen mimickers, right? So we can look at a lot of different labs and say, ooh, I think you might have a heavy metal issue because uric acid is through the roof or something, or albumin is through the roof. Sometimes those are signals. So really looking under the hood and figuring out and also asking all the right questions, right? What are your toxin exposures? Is your sleep history? What is your exercise routine? Thinking about all of those things as a very comprehensive approach. Yes, we talk about insulin all the time, but really interesting, like some of the sleep apnea data, just changing patients to a low carbohydrate diet can improve sleep apnea in and of itself, before weight loss, before anything. So it's not, again, but they all impact each other, right? Sleep apnea causes insulin resistance causes sleep apnea. They're all very circular. So super interesting. But yeah, I do feel like we have to be cognizant about all of these things, but they're never talked about in the conventional world for sure.
And sometimes it's hard because, for me, the last year I've been really looking at the effects of stress and sleep and all these things on our metabolic health. And it's hard when you see someone who's totally stressed out and tense. Now you're telling them, okay, you're killing yourself by doing these things, right? And it's so hard because like we have to figure out like lifestyle and modifications and how do I, have boundaries in life and all those things. But some of those things I've seen with, for instance, one thing that popped in my head that came up is, Seafried and a lot of the people working with oncology, they're saying, okay, you want to have your glucose ketone index at a certain level. So people get super stressed because they're not at that level. It's like, okay, I don't want you to be stressed out. Like, try to do what you can do. You know what I mean? And some people will be very militant and they're trying to get there and they can't, and they're freaking out because they're not, and that's screwing up. So they can't get there. You know what I mean?
Well, and I will say we don't have a ton of data on what the right one is. So I really don't pressure people to hit any particular number. And to be honest, some people, like maybe some really thin person that doesn't have, like, okay, how does this thin athletic person produce ketones versus this morbidly obese person that can now start just dumping fat into the system?
Yeah, exactly.
Potentially. But what we don't have is we don't have that data. But what I do have is that insulin matters and IGF-1 matters. And so as long as they are moving their numbers in the right direction, then I'm not asking them to hit any particular number per se. I think that data is lacking right now. It's great that we have a lot of trials that are ongoing, but a lot of them are testing, folks' ketones, and they're like, oh, this guy could only hit 0.7. Like, are we going to freak out? But we're still going to, but wait, he's still having really good responses. Like, so I think it's a surrogate. And if you look at the data, right, like any surrogate, there is a direct correlation to higher ketones equals lower insulin, but that's not on an individual level. That's on an average. And we always have to come back to the individual and personalize those recommendations.
Yeah, and I think that comes back to like, one thing that, I was at a conference I ran to Ben Bickman, and we were talking about, I go, Brian, Ben, if I want to live a long life, what do I got to do? He goes, okay, Brian, there's 5 things you can do, right? And all these things have to do with insulin, like insulin levels overall. He says, number 1, don't be stressed out and run around working 18-hour days, which I was doing at the time. Make sure you get enough sleep. I was like, I don't like your rules at all. I'm 0 for 2 and there's only 5. Eat real food, cut out processed food, right? Don't smoke or drink to excess, exercise regularly. That's it. And you go, and all those things lower insulin. It's the same thing you're saying. Like, we're all saying the same thing in a different way.
Get great sleep, get great sleep. Also lower,
don't be upset with Tro on Twitter, all that kind of stuff, all those things going like really, because in our society we feel guilty if we go and just go stare at the ocean for 10 minutes or something, or play with your dog. You're like, I got too much stuff to do. I can't do that. So people listening will know what I'm saying, because I was in that lifestyle for a long time. But being under this constant stress, not sleeping, tense, and feeling bad if you go and have fun somewhere, like having fun is like a sin these days. It's amazing.
Yeah.
I think those simple things, those simple things mean so much. And, having had, so many patients, I'm just thinking back at the cases of cancer that we've had, just be not only, helping them conquer that fear. I can't put a price on that, helping them become empowered in their, cancer treatment. There's no price that you could put on that. Giving people hope, and there's no price you can put on these things, and they have nothing to do with, okay, we can go back to clinical trials and say double-blind, placebo-controlled, but what about the quality of that person's life when they're here? And I think as doctors, we forget about that yeah, we have to know the double-blind trials and what's going to do better for outcomes, but we also have to know the side effects and how can we improve that person's time here on Earth, in the meantime, and I'm sure, Christy, you're probably a friend. I mean, some of these people probably have nowhere else to turn to. They're like, I want help with my metabolic health. I want help with my diet, and their teams are probably, I can't imagine they're supportive. How do you navigate that?
Yeah, I will say that I am their hope fountain, because I feel like so many conventional doctors are doom and gloom, and it's like, oh, you have metastatic disease, man, you're dead. I mean, honestly, they really put the fear into them. And yet we see people live very, very long time, even with metastatic disease, if we are really optimizing all these pieces. I've seen people, their bone metastases, we can't find them anymore. Their liver metastases are these really aggressive, uh, you know, uh, tumors that aren't supposed to respond, and they do, and these doctors are like, wow, I've never seen this happen. But they never say, what are you doing? Like, what are you doing differently? This was just the one-off. And I will say that it's very tough, for instance, with the weight loss. Yes, we might be taking inflammatory fat off of a patient, and then they're worried that this patient is losing weight during treatment, and that's bad. And I'm like, well, unintentional weight loss would be bad. That would suggest that we have some form of cachexia or something going on, but this is intentional, and you're feeling better, and you're tolerating your treatments well, and so this is okay. So a lot of times I will have patients meet with me right after they met with their oncologist, or right after they got results, because they'll listen to their oncologist or their radiation oncologist, and they'll listen to the doom and gloom picture. And then they come and talk to me, and we'll say, let's think about, what is this telling us? Because the conventional doctors, again, they don't think that the patient really has any power, right? The conventional treatment has the power.
Yeah,
and so when they're right, so they will always say, oh, no, this isn't you doing anything. You don't have the power to make these things look better. But yeah, so I do always come back to, I'm telling you that you have far more power than you think you have. Like, let's embrace this. And I try to give patient examples anytime I can, because that provides hope. And hope is really powerful. I had somebody diagnosed unfortunately, very, very last minute, like really, really advanced, like terrible. And she really passed quite quickly. But the husband reached out to me and said, thank you so much for providing at least a little bit of hope, because that made her last, number of weeks on, of life so much more bearable. And I didn't change anything because of where she was, but I gave her a little bit of, let's not just spend the last few weeks of your life dying, but let's spend them living.
Well, at least trying that, as a matter of fact, for me as a doc, a good friend of mine got diagnosed with pancreatic cancer, metastatic. It was a disaster. And I said, I'll go with you to the oncologist. Oncologist like, oh, you're going, to the appointments with it. Anyways, the thing was that they put him on treatment. I told the oncologist, look, I know this guy really well. If he's not going to respond to treatment, let's not just flog the guy. He's not like, yeah. Anyways, we put him through chemo, and his tumor size shrunk by like 50-60%, something like that. But he was absolutely miserable in the hospital all the time, going through all this stuff. And I remember sitting down and showing him his MRI. I go, look at this, look at it, shrunk. And he looked at me, he was like disappointed that it shrunk, because he goes, I don't want the treatment anymore. I was hoping it didn't work so I wouldn't have to do it anymore. I'm like, if you don't want to do it, let's not do it anymore. I'll help you through this. And that's what he ended up doing, because he was so like, people don't look at like, okay, it extends your life by 8 weeks, but for 6 of those weeks you're sick as a dog. It's like, okay, that's not worth it. So it's hard because it's hard because no one knows how you're going to respond either, and you have to see what happens. I mean, it's really such a tough thing. You don't want to just give up, and then like you're saying, like people say, you're giving them false hope. You know what, I'll take any hope. If I lose all my hope, give me any hope I got. I don't care if it's false. I don't care what it is.
Yeah. And what I wish is that, there is some data, right? If we put people in ketogenic states during chemotherapies, they actually tolerate it better. There's people who've gone through chemo both ways are like, I will never go back to chemo without being in ketosis. And so I feel like we could give people even more, right? If they tolerated that treatment better and they got a reduction, they'd be like, okay, woohoo, like I got out and I golfed another round.
From personal experience, I had that one. My wife's best friend got metastatic breast cancer, right? And so she had to go through chemo, and they were asking what would you do. I'm like, okay, it's not my area, but for me, I would look into Nasha Winters and all these different people
Yeah.
that I would at that point. So anyways, she goes on a ketogenic diet. She went through the radiation and the chemotherapy, and the doctor, my wife would take her to all those. She would drive up to Orange County to take her to the appointments, and the doctor says, I'm so sorry because I know what's happening. I give you the chemo on Monday, you feel like crap for like 8 days, until your next treatment. The day before you start feeling better, and we give it to you again. And my wife was like, she's out gardening the next, she's out doing, she was in ketosis, and her husband was fanatical, like pouring olive oil on everything and butter and all. And he goes, I'm all in. We're gonna do this. And she went through chemo with like flying colors. Like it was unbelievable. And the doctor didn't believe my wife when she was saying she's doing great. She's not sick all week. And he goes, I've been doing this for 38 years, and all my patients are sick all week. And she goes, she's eating, she's going for walks, she's enjoying life. And yeah, it was crazy.
Right? Why can't we be spreading that word?
The sad part is this. Tro and I have someone we know in metabolic health who was working for a huge university system, and he got fired because he told people going through chemotherapy that they would be doing better if they're in ketosis when they go through chemo. And the oncologist found out and had him fired from that job. And you go, wow, he was giving the right advice and he gets fired.
Yeah. Well, that seems to happen a lot in conventional medicine, right? You go against the talking points and you're done.
Yeah, it's such a problem. I think the fact that these common sense things are becoming not so common anymore. Even I was talking about this the other day. You mentioned my hilarious Twitter account. Why is it that clinical observation is so important, right? And seeing these people improve in front of you, talking about it, documenting it, this is like testimony. This is like the most basic way to bring new sort of medical evidence. And the truth of the matter is if you make a discovery, you make something that nobody else is aware of, or very few other people are aware of, right? It comes from medical observation. So medical observation and everything that we're talking about right here, it could be like literally decades before it makes it into mainstream medicine,
50
potentially
years,
even centuries. So yeah, it could be even a century. Right. So look at, Banting, and look at all, it's 100 years later, and finally we have a Society of Metabolic Health Practitioners. We have a Journal of Metabolic Health. This is finally becoming, a force in conventional medicine, I guess. So but I think we forgot that power of that observation. Right. All these patients that you've seen, all the patients that Brian's seen, Christy, you've seen.
The three of us together, we could talk about this and say, what are you seeing? What's working? What's not working? And we can look at that. I don't say, well, I need a randomized controlled trial to say what happened to Betty, right? I really don't need that. I know what happened to Betty based on treatment. And the hard part is you look at the history of medicine before pharma came along, like it was all that. They go, Tro, what are you doing over there in New York? What am I doing? Look at my success rate. What's yours? Okay, let's try what Tro's doing. It's working better than me. We adopt that. And that's how it's always worked. Now they're like, well, we can't, all your patients are surviving. Look at, I'll tell you, look at Pierre Corey when he came out and said, high dose steroids, my patients are not dying. And he cried and he was like begging them. It took a year before they put that in and go, oh, it does work. How many people died as a result, being not listening and saying, let's try it at least and see, let's run a study, let's do something. So when people are having success and they're saying, please, it's working, try it, see what's happening. The people who are nutty are going to go, don't try what I'm doing. I'm the only one who can do it, right? But if they're trying to change and help people, it's so maddening that, that people will die because they're not going to learn. Let me look at my metabolic health while I'm going through the standard of care treatment or whatever we call it. But the reason we started this podcast is it was exactly that. The standard of care is what the doctors are doing. So in order to improve the standard of care, you have to change what doctors are doing and get them to see the standard of care that we have now is horrific. If people are dying all the time, you go, okay, it's not working. Let's change and try something new. And it shows a better outcome. Then that's the standard of care now, right? The standard of care that's not working is not the standard of care you want.
No, you always have to challenge it. What is a randomized trial anyway? But where do those evolve from? Because somebody tried the other thing first and said, hey, I think this is better. Okay, let's do a randomized trial. But when you and I and Tro, like we're seeing over and over and over these successes within our own practice, we cannot unsee what we've seen. We know that if we can just get the patient doing, a number of things, that they will have success. Again, like maybe we miss something. Maybe there's some, toxin that is in their house that we don't know that, blah, blah, blah. But for the most part, I feel like we can really turn around people relatively quickly. The number of people that within days are sending you notes going, oh my gosh, like I couldn't do this 3 days ago and now I'm doing this, or, whatever it is. But it's pretty impressive. And it is sad that we're to a point, and I felt like this was coming out when we started getting these national guidelines, right? And then we were getting institutional guidelines. So they were trying to keep us here, because the way that we all advanced was I was doing it a little this way and they were doing a little this way, and then we would be like, hey, that really worked a lot better, let's do that. But now they're like saying, nope, you got to follow this path, and it's really tamping down on us discovering better ways to do things.
Can I share a little segue, just because we can actually institutionalize this process. So what you guys are talking about, comparing, contrasting, seeing what happens, the way to accomplish this in our current paradigm is actually through machine learning, right? And it's like when Brian and I work closer and closer together, we plug our data into a combined data set and run machine learning. We are setting this up right now in our own clinic, and we are able to learn an immense amount in like near real time. What does it mean when somebody's glucose level drop? What does it mean if somebody's insulin markers are low, inflammation markers are low? What does it mean when they're both high and the nutrient markers are depleted? So this real-time access to data, and then to be able to compare data, well, what is it about Brian's patients? Why does he do so well with, certain populations? Why is it that I do well? Can we compare what's the difference between these groups? And I really think if we start to get the technology right, that we'll be in this golden age of medicine, because we can do these in instances, right? Imagine what it took like 30 years ago to compare. Hey, Brian, how's it going? Tell me about your patients, what you're doing, what's working, what's not. Hey, Christy, what's going on with your patients? What's working, what's not? Imagine in real time learning this. And that's sort of where we're heading in medicine. And that's the kind of stuff that gives me hope. It's that, like, these things that we know work, we're going to be able to do them better and better.
That's awesome.
Yeah, sorry to segue. You guys got me all excited. You got me all excited.
Yeah, nothing can displace clinical experience and human connection. Nothing can displace that. Even you can have all the AI and all these other things, but I think what we're doing in medicine now, we're selecting for people who are just going to follow the guidelines. So you say that, okay, number 1, you do this drug. Number 2, you do this drug. Number 3, you add this one, then you do this. This is how we manage diabetes. And it's like, have you ever talked to the top patient? Or they'll say, talk to the patient about lifestyle, but they don't tell you what lifestyle is. And then they say, okay, when that doesn't work, do this drug, this drug, this drug, this drug. And you're like, okay, like it's insane how it's been captured. It is really incredible. And so then you have to have someone like Jason Fung who comes along and who just says, look, this is idiotic. Here's why. And he goes through and you say, oh, I never thought about that. Like sliding scale insulin. Why do we're managing it with carbs? Why don't you take the carbs away and see what happens? And all these things. And oncology, it's such a scary area for all of us. No one wants to get diagnosed with cancer. Like that's a scary diagnosis. And then when you say, okay, here's the physiology here, I understand this process, and you can sit down with someone and explain it. I'm telling you, oncologists have gotten horrific at explaining anything, the mechanisms, what's happening, holding your hand. Like, it's like, okay, go line up. There's the chemo. We'll see you in 2 weeks, that type of thing. It's really a tough one.
Yeah, I agree. And I feel like I was always one that kept that patient perspective in my practice, and try, again, using education, using the data that we have, and what do we know and what do we not know, to really try to motivate people. But from inside the conventional world, I didn't have as many people that were really interested in doing the work, because optimizing your diet and your lifestyle, it's work. You are responsible for that. No one else is, So again, I think that the idea I love this, Tro, of like taking, okay, here's all my prostate patients. Here's how all their markers changed. Here's what they were doing, like which ones succeeded better,
and who didn't
what were
do
they
well,
doing, and who didn't do well, what did they do differently? Like, I think that's what we always want to say. What are those guys that are actually improving their health doing compared to those who aren't? And do we have real markers? I go back to the data. What are all these inflammation markers doing? What are all the other metabolism markers doing? What are all these nutrient markers doing? Because if we can get those on point, if we can figure out what it is that patients do to get those on point, that's really powerful.
Just imagine what it takes. So what do we use? Like one of the tools we use in metabolic care, just to help the patient understand what's going on in their body and, in their own sort of dietary lifestyle practices, right? We use biofeedback. We use the CGM, which I'm wearing a Dexcom CGM right now. But if you look, we need to create that for physicians. We need to create a way for us to get biofeedback. How are our patients doing? How are we doing as a whole? When, at what point, 6 months later, are they gaining weight, or 8 months later, 9 months later, how do they do? What happens at 2 years? What happens to A1Cs at 2 years? What happens to depression scores at 2 years? How can we tweak our own practices and understand how we're performing? We need those tools, right? We need those biofeedback tools that we use with patients. Are you making ketones? Are you making, and it all comes back to, machine learning and data processing, right? Like these are complex data things that we have to, figure out a way to sort of bring this into the standard of care. I'm excited. When Brian says, Tro, I can't wait to take a step closer, work together. When Christy, you say, I can't wait to take a step closer, work together. We got an SMHP. We have a Journal of Metabolic Health. Like, this is how we're going to advance, in my opinion. And I'm just excited. You guys got me all excited,
Yeah, no, I'm excited too, because it's really about helping the patient. So I want to have the best, if a hypnotist helps my patient, I'll use a hypnotist. If an acupuncture helps, I don't care what it is. If my patient does better and they have success, if I'm not the one to give them that tool, so be it. It doesn't matter. As long as we work as a team. There's nutritionists out there who are great. There's great, exercise people out there, Ben Bakikio being one of them, and it's not one approach for everyone. Someone goes, I hate to lift weights. Okay, let's try this. Let's do something. What works for you? And I think in oncology, say, okay, let's look at what our goals are to give you the best quality of life. Even if it's not going to be as long of a life as we thought you might, let's make it the best we can. And then sometimes we get lucky and everything goes the right way, and all the paths align and everything's good. Now, do you have any low-hanging fruit, like you would tell people, look, if you're worried about cancer, everyone in your family had cancer, here's some things you could do now that will help prevent you from having to see me down the road, or supplements, or lifestyle changes? What do you think are the big, like the low-hanging fruit that you could say? Okay,
it's exactly the same thing that you tell patients, right? It's about getting rid of the processed foods and the seed oils, and optimizing your real whole foods, ideally in a low carb, nice animal based way. It's getting the sleep and reducing stress. If you're working in a job that you hate going to every single day, and there is conflict every single day, you might want to rethink that. Like, there is no amount of money that's worth your health. Like, so I think there's a lot of things that we can always look at, but I always say, get some basic labs. Let's know, what is your fasting insulin? What's your HOMA-IR? What's your triglyceride glucose index? What's your triglyceride HDL ratio? What's your vitamin D level? Like, let's take some basic information that is super easy to get. And then let's just see, what can we do from a diet and lifestyle perspective to optimize those?
It just makes sense, right?
Makes a lot of sense.
And how many doctors, I mean, I appreciate you talking about insulin levels. How many doctors have checked? How many people listening right now? Maybe our listeners are different. Yeah. But when I speak to people, I'll go, how many of you ever had an insulin checked? And they're like, no one's ever heard of it. I talk to doctors. They don't want to deal with the data. They don't know what it means.
They don't know what to do because there's not a drug that treats insulin. Only diet and lifestyle treat insulin. Well, I shouldn't say that, because there's a little bit that can help with insulin, like a metformin, but it's barely, right? But the the bottom line too is I have asked people that have looked at insulin as part, and I'm like, so what, like, what was the insulin of these people? Oh, it was normal. That's what I get back, right? Okay, well, normal. Do you know what the normal ranges out there are on LabCorp or Quest or your hospital labs? I mean, it's like from 2.0 to 24.
26. Yeah, my labs is 26.
It depends on which lab. I have one that's 19, one that's 24 and a half, one. That is not normal, people. That is so high. You are diabetes waiting to happen or cancer waiting to happen. Like, we need those low single digits, people. So even if you're getting them, don't look at the standard reference ranges, because those are very misleading.
So are you, I know you're near Chicago. Do you take patients outside the state? How do you do online consults? What do you do?
Right now I'll do kind of more of a coaching type outside.
Yes.
I'm not prescribing across, state lines, but I'll help them. I'm always willing to help give them advice as they're going through treatment. So yeah, I'll see folks, and a lot of people, I've even seen people across the world, because they'll get their own labs for me locally, and they'll say, can you just help me interpret? And what do I need to do? Here's what I'm eating. So yeah, I'll help people anywhere.
Awesome stuff.
How do people?
They can go to my website, kessrx.com, KESSRX.com. And there's a place where either you can schedule an appointment, schedule a discovery call where we kind of talk about what kind of labs might we want to look at. Or they can just send me an email. But most of the time I refer them back to, hey, schedule an appointment, because let's talk through this. So sometimes getting to know, right? So if somebody's got issues with like autoimmune issues, that might be a slightly different panel than someone who's just, obese and obvious insulin resistance type picture. But as you know, cancer patients, nor do type 2 diabetics or anybody, do they have to be obese, right? We can have metabolic dysfunction at any size. But so usually my website is the best way to get to me. And then that automatically sets you up in my electronic medical record. I like my little system. It works out well.
That's great.
Awesome.
Oh, and
That's great.
I have a question just off the cuff a little bit. In San Diego right now, it's almost impossible to get someone who's an oncologist without an extended wait. Are we seeing a huge uptick of cancers in recent years?
I don't know for a fact, because I'm no longer in conventional medicine, but from my colleagues who I've been talking to, yes, it's like, oh, we're going to extended hours. Oh, we're going to Saturdays. Oh, we're, like we just hired 4 more people. Oh, so just from those conversations, I believe that yes, there is an uptick. My practice is, up to capacity, essentially. Yes, I'm still taking new patients, but it's like a very organized new patient intake. But I don't know if my uptick is just, again, the complete ramping up of my practice versus
word of mouth.
Are we really seeing more? I just think that our word is getting out there. And so I'm seeing
patients around longer.
Yeah.
That's a good news that you're not having a ton of turnover in openings, right?
Right. Well, and to be honest, sometimes, as I get people on the right path, they now know what to look for. They now know how to evaluate their own labs. And so I don't have to see them. So a lot of patients I'll see a lot up front, and then, then we really extend our visits just like
every 6 months or 4 months or whatever. Yeah, that's kind of what we're doing now too, more so, is like,
so
hey,
some of my really new onset active cancer patients I will see every month. Like, we need to tighten this up very quickly, and then, less. But yeah, I think that probably there is an uptick, but I would say that we were seeing upticks, for many years, right? We're seeing younger and younger people being diagnosed with cancers, just like we're seeing younger and younger people being diagnosed with diabetes. Because
we have more obesity and lifestyle and
I think it just goes hand in hand. We're just on that up trajectory. And I just hope that as we continue to spread the word and get, more people aware, it's amazing how many people have never even heard of this, but when we start seeing people who are actively pursuing this, right, it's totally a grounds up, so.
Awesome stuff. Thanks so much.
Awesome.
Thanks for your education and for sharing what you're doing. It's really exciting. And it gives hope, because I always want to have someone that my patients, if they do get a diagnosis, say, okay, here's someone who knows, like this is what they do, and so it's amazing. Tro, you have any words of wisdom for us today?
No, it's great. Thank you. Thank you for coming on. Thank you for, sharing your experience and sort of your approach. And, it's always nice to meet somebody who's, thinking along the same lines.
Yeah, absolutely. I appreciate the time, and I can talk about this stuff forever. So I think we're all in the same boat there.
Yeah, that's like my wife, when we're out to dinner, someone asked me something about metabolic stuff. I'm like,
Like,
she looks at me like, oh no, I
not
gotta be
again.
somewhere. But I love it. It's fun to talk to people and help them and give them pointers, and it's good. We're doing good work.
Agree.
So I thank you. I
Agree.
thank you so much.
Yeah. Thank you.